Doctors are being urged to stop dishing out drugs and advise patients to change their diet and lifestyles instead.
Leading medics from the Academy of Medical Royal Colleges argue that administering tests and treatments can sometimes cause more harm than good. And we're joined now by one of the authors of the report, Dr. Aseem Malhotra. Good to see you this morning.
Good morning.
So what sort of drugs then are we talking about that are being given out ill-advisedly, wrongly, and what kind of harm are they doing?
Okay, I think the first thing to say is a culture of more is better, doing more, giving more medications, more investigations, have actually led to an unbalanced decision-making process in the consultation room. And the root cause of this, and this is a systemic problem, stems from a number of factors. Biased funding of research, so that's research that's designed because it's likely to be profitable, not beneficial for patients.
So you're talking about drugs companies funding research into better quality drugs.
That's one element of it. Biased reporting in medical journals, commercial conflicts of interest, patient pressures, of course, defensive medicine, and also an inability of doctors and patients to understand health statistics. So all of these factors have kind of conspired, really, and created this culture which actually, causes potentially considerable amounts of harm and great cost, and reduces quality of care. So this is about winding back from those harms. So one example would be treatment of mildly raised blood pressure. So independent researchers at the Cochrane collaboration in Oxford did very good reviews on this and found that actually if you treat people with medications who have slightly raised blood pressure, which is actually almost probably more than half of people in the UK being treated with mildly raised blood pressure at low risk, then actually it didn't benefit them in terms of reducing the risk of stroke, heart attack or death, which is the reason they're being prescribed
medication, which in your opinion is not helping. What could be helping them instead? Because presumably if you go to the doctor with mildly raised blood pressure, you're worried, and then your doctor is worried, and your doctor says, actually, there's a drug which can help you. Where's the problem?
Absolutely. So I think that we have, in a way, we've exaggerated the benefits of many treatments, not really fully understand the evidence base. So actually what would be better, and part of our role as a doctor is to reassure patients, is have a conversation. I do it all the time. I mean, I've stopped medications on people that I didn't think was benefiting them, but I explained why I was doing it, and patients value that. So it's about having that conversation, a shared decision-making process. Now, it doesn't always mean that, you completely stop treatments that patients want to have, but it's about making a more informed decision.
You're talking about a very ideal world, though, aren't you? You're talking about time for GPs to talk to their patients, which they don't have, and there's no funding for that. And you're talking about doctors having to make a call about whether they can let their patients go out and trust them to do the things you're suggesting, which I'm not find that, months down the line, their blood pressure's through the roof and they're at risk.
Sure. But I think that this is actually looking at the independent evidence space, and you're absolutely right. So what we need to do is also create, if you like, more shared decision-making tools within medicine so GPs and patients can actually make an informed decision and getting that information out there.
But Dr. Malhotra, what I don't understand is, we are in a world where we have enormous medical advances and drugs either work for conditions or they don't. How can we have a situation where you're saying GPs are prescribing drugs which don't work for conditions and therefore they should be using other things instead? Aren't these things cut and dry?
Susanna, I think that's a very good point. I mean, it's not black and white, it's more nuanced than that. And, some of these drugs will have marginal benefits, but that information, the way that it's perceived, is often quite grossly exaggerated. So, you could take a drug, for example, that, I'll give you one example. So, statins, cholesterol-lowering drugs that people at low risk, they do have some marginal benefit, but if you have a low risk of heart disease, there's about a 1 in 140 chance that taking a drug such as a statin will prevent a non-fatal heart attack. It won't prolong your life, but there's a similar risk that it might give you type 2 diabetes. Now, some patients will say, listen, doc, I'm actually really worried about a heart attack, I want to take a statin. Other patients will say, actually, weighing it up, I don't think I want to take it. But doctors should respect that decision, but we need to be more transparent in that conversation to improve quality in healthcare, and that's what we need more than anything else.
All right, Dr. Aseem Malhotra, nice to talk to you this morning. Thanks ever so much.
Thank you.